All right, so now we can determine the slope. And you hear rabbit ears. And what you hear is, you're talking about something like that, right? Versus like that. They say if the ears on the right side could be a right bundle branch, left side could be a right. But you can actually have ears and still have a tight QRS. So I want you to know right, complete, left, the way we just talked about. Lead 1, go to V1, upward, downward deflection. Austin, question?
Also, I guess some people may be saying that if you had an RR in V1, it was right. If you had RR in V6, it would be left.
Yes, and now probably I'll utilize that more when we deal with vesicular blocks. But yes, it could. Yes, that's the same thing what he's saying. It's the same thing what he's saying. But the only issue is you can have that, and that creates the rabbit ear. And you can still have a tight QRS and have that. So is there a problem in the conduction system? Yes. But has it become a complete blockage? Not yet, but probably on its way. So you can use those methods. People use those methods all the time. This is just one easy method to determine left versus right. This is what everybody uses, what everybody should use. All right? So we keep it simple. KISS, right? Keep it simple, student. All right. So we have vesicular blocks. This is what I need you to know about vesicular blocks. First of all, vesicular blocks can only be on the left side. Why? How many branches do we have on the right? 1. So any block on that right branch is a complete block. Everybody with me? Now, how many blocks does the left side have? Branches, sorry. 2. How many branches? 2. So if I have it here, I'm blocking all signals. We know that. But if this is good, but if I have a blockage here, can it still go down the other one? Sure. Yeah. So that's a vesicular block. How about if this is good, but I have a blockage here? What will you call that? A vesicular block as well. So we have an anterior branch and we have a posterior branch. So if it's on the anterior branch, we call it an anterior vesicular block or a hemi-block. Hemi-vesicular means the same thing. If it's posterior, it's posterior block. How about if I have here and here? Still one. It's still one block. It's just a bifasicular, or it could be a trifasicular depending how many we have. If it's 2 or more, then it's bifasicular. If it's 3 or more, how about I have one there, and one here? Yeah. Still on the branch. It's not on the main road. It's on one of the side streets. Vesicular block. All right?
If you have like a block on the side streets and on the main road, then it doesn't matter.
It don't matter. If it's on the main road, it's a... It's a what? It's a complete bundle branch block. It's on the main road. It's a complete bundle branch block.
So vesicular refers to the side of the road.
It's talking about one of the branches. And that can only be on what side? Left.
Have you seen them in your career?
Yeah, people have them. People have them. They're not that significant compared to a complete. Complete, you're blocking all the signal. So yeah, people do have them. People do have them all the time. All right. Let's talk about early depolarization. We kind of touched on this a little bit back in part 1 of cardiology. But early depolarization is the ventricles are depolarizing sooner than they should. So that means that the SA has fired, send the signal to the intraneural pathway, the AV got it, and this is where the problem becomes. The AV is supposed to hold it for a certain amount of time and then send it to the ventricle, right? With a early depolarization, it grabs it and sends it. It doesn't really hold it much, just sends it right back. Grabs it and sends it. So that means the ventricles are depolarizing a lot sooner. So we know normally if the SA fires, we got that P wave. Then you got that little delay, right? That little delay for AV holding that signal. And then the AV sends it down. And then the ventricles fire, then they repolarize, right? That's normal. So that delay is normal, correct? As long as it's within what? That whole PR interval is within 0.12 to 0.20. Very good. No more than 0.20, right? But with early depolarization, this is what's happening. The atrium's firing, it gets it to the AV, and guess what the AV does? He sends it right to the ventricles. Sends it right there. It can look like that, or it can look like this. But you see, they go right in. There's no pause. Everybody see that? But what you notice about this one, it had a what? A little hump. You see that hump there? And then this one slopes. That's a sign of early repolarization. We call that the delta wave. So it goes right into it. Can everybody see the slope and see the little hump? You can have either or. That's considered a delta wave. So what's that disease called? WPW. WPW, Wolff-Parkinson's-White. Okay? So what's going on with Wolff-Parkinson's-White when we see this? When this happens, why is it depolarizing early? What's going on? How? Correct. And then you say, what is the biggest problem with WPW? So what happens is we have the SA node, which we're familiar with, intranodal pathway, AV node, bundle His, and then the bundle branches, right? And we know that the AV sits where? On the bottom of the floor of the right atrium, right? So that means the only way to get into the ventricle is via what? The only way electricity should enter the ventricle is via the AV node. Only way it can enter is through the AV node. That's the only connection. With WPW, you have an alternative pathway. So you can have a branch that branches off the right side, it goes into the ventricle, or you can have a branch off the left side that goes into the left ventricle. It could be on either side. We call that the bundle of Kent. The problem with the bundle of Kent, it doesn't have an AV node. So if electricity hits that bundle of Kent, where's it going? To the ventricles. All right? So it could be on either side. Now, why is that a problem? Multiple reasons. If I come down this bundle of Kent and electricity is firing, I could catch the bundle branch. If I catch this branch, what's going to happen? What's the electricity going to do? And then now it catches this, and guess what it does? Speeds up. It's like having two mics, two speakers in the same room. You say, hello, 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 hello. What's it doing? Looping. Same thing here. So my rate that was 110, I caught the branch, and now it starts to loop. My rate goes from 110 to 220.
So you're on V10?
Well, you're SVT, and then quickly we end up in that rhythm if we don't do something about it. So you see how you become lethal? It could do it the other way around too. It could come down the AV node, hit the bundle of His, bundle branches, and catch that bundle Kent. If I catch that bundle Kent, what's it doing? It's going to loop this way. So one loops one way, one can loop the other way. That's the difference between calling it orthodromic and antidromic. Orthodromic coming down, AV, orthodromic going the opposite way. Orthodromic and antidromic. Antidromic is going the opposite. See what I'm saying? Is everybody with me? So if I go the opposite way, meaning I come down, am I going the opposite way? I'm going back up. I'm sorry. The opposite way would be the other way around. If I come down the branch and I come up the branch, up the AV, is that the opposite way? Is that a normal way electricity travels? So what should you expect your QRS to look? How do you expect your QRS to look? Not completely flip, but what else? Wide. It's coming from where? In the ventricles, back up. So wide. So you got a wide QRS with WPW.
So it wouldn't always be, it wouldn't necessarily be flipped, but it could be flipped.
Yeah. Mm-hmm. Yep. So we don't care right now. I don't want you to get hung up on is it orthodromic, antidromic. I want you to know how to identify WPW. And I want you to understand the significance of WPW. All right? Easy to identify if we look for it. If we look for it, we find it. Anybody ever seen those like videos with illusions where things happen? They had the one I remember is, The girl, and I don't want to talk about the girl because it's being recorded. You ever seen the guys playing basketball? There's a bunch of kids throwing the basketball back and forth. And there's a lot of action, a lot of stuff going on, and then a gorilla walks right by. And you don't see it. And you don't see it. And they say, you notice what you saw? And it was a gorilla, a guy in a gorilla bear suit. And it's supposed to be a gorilla suit. But he walks through, and nobody sees it. You don't see it. Initially, you won't see it. You'll look at it and be like, there was nothing wrong. And the guy walks right through in the gorilla suit. Boom. And then so they play it back slowly. You see him. He goes right through it. So those are, and I like to think of WPW as the same way. Meaning, if you don't look for it, you won't see it. But when somebody points it out, you say, hey, this guy's WPW. You'll look for it, and you're like, oh, wow, how did I miss that? It's so obvious. So obvious. So you got to say to yourself, who has WPW? Well, most patients at WPW are under the age of 50. It's not often seen over the age of 50, rarely seen over the age of 70. So that tells me two things. What population would I most likely see WPW in? 40, 50. The young, less than 50. That's everything. Don't shorten the less than 50, right? Also, because WPW could catch the branch and do what to the rate? We'll increase it. So if I have a young person in SVT, guess what's under 50 years of age? Guess what the first thing I look for? WPW. And if you do that every single time, you'll catch it. Because all you're looking for is one or two things, right? We're looking for the delta wave. It slopes right in. You're going to see that delta wave. Or it's going to what? Slope. Huh? You should be able to see it, but if you can't see it, what can you do? Slow it down. And depress what? Print. Okay? All right, very good. Now, that's WPW. Any questions as far as that's concerned? Now, you remember we talked about right axis, left axis deviation? If I have right axis deviation and they have a history of WPW, where's that bundle of Kent at?
Right side.
The right side. If I have WPW and I have left axis deviation, where do you think that bundle of Kent's at? Left side. So you could use deviation to help determine where it's at. All right. Fair enough? Everybody with me? That's why we don't give calcium channel blockers are contraindicated in patients with WPW. Why? Because the whole conductive system works off the sodium channels except for the AV. AV works off the sodium channels. So sodium allows those channels to open. When those channels open, electricity fires down to the ventricles. If I don't have calcium, calcium opens those channels. If there's no calcium at the calcium channels, then they open up slow. They open up slow, the signal is delayed. It doesn't go down, it slows down the rate. If I have calcium, they open up and they fly down. So I give calcium channel blockers to do what? Slow the rate down. So where's that slowing it down? At the AV. I block calcium at the AV, I'm slowing down the rate. I'm slowing down the delivery of electricity when my rate's going to start to slow down. That's why we give calcium channel blockers to tachycardic dysrhythmias, because it slows down the rate via the AV conduction. You with me? But when I have WPW, if I start slowing down the rate with calcium channel blockers at the AV, what could it do? Use the accessory pathway. It has an alternative pathway. So it's going to take that pathway. And the problem is I don't have an AV node. So whatever my atrial rate is, so will my ventricle rate be. So if I have an AFib patient and I gave calcium channel blockers, let me tell you, AFib, A-flutter, we give calcium channel blockers all the time with no WPW. It's a standard medication to give. So if I miss the WPW, I could jack my patient up because their atrial rate could become their ventricular rate. So if my rate is 300 atrial-wise, and that happened, my ventricular rate becomes 300. How long do you think a patient could withstand a ventricular rate of 300? No, so he goes right into a lethal dysrhythmia. Does that make sense? That's why calcium channel blockers is contraindicated in SVTs. All right, any questions so far? All right. So we have what's called, we're going to look at chamber sizes. We're talking about the atrium, talking about the ventricles. We want to know the size of the chambers. And if they're abnormally large, we call that atrophy. Abnormally small, we call that, anybody know? Atrophy. Atrophy, abnormally low. Abnormally large, you call it hypertrophy. I think I said atrophy, right? I meant to say hypertrophy. Hypertrophy is abnormally large. Atrophy is abnormally small. All right? So we're going to talk about atrophy, ventricular atrophy or atrial hypertrophy. I keep saying atrophy, hypertrophy, sorry. So a wide R wave in the ventricles may be a sign of enlarged ventricles, left ventricular hypertrophy. And what they mean is abnormally large. So it looks something like this. And you get that slope down. But that R wave is super tall. That's a sign of left ventricular hypertrophy. We're going to show it now, okay? So let's talk about that. So let's talk about right atrial enlargement, the right. What represents atrial contraction on an ECG? P wave. So if I have atrial enlargement, I'm going to have a problem with my, very good. If my atrial is abnormally large, then my P wave is going to be abnormally large. All right, so the P wave is going to be the issue. So the height is going to be higher than 0.2 millimeters in lead 2. 2.5 millimeters. How big is that? How many boxes?
5.
What is that? 2.5 little boxes. 2.5 little boxes. I don't know what he's reading. All right. So 2.5 little boxes. If we have a P wave that is really high, greater than 2.5 little boxes, we have atrial enlargement. What side? Right atrial enlargement. So, and if you see here, if you look at lead 1, I will point with the mouse if you see. Look at the P wave. See how tall it is? It looks like it's part of the R wave, but it's not. But you see how tall they are? They're big. That is right, once again, right here. This is right atrial enlargement. So look how tall. It's greater than 2.5 little boxes. You could pick that up immediately. All right? That is right atrial enlargement.
So that P wave has to be large, and then you will look at the other leads and if it's long QRS complexes.
Well, then we're just talking about right now atrial enlargement. That's something separate. Ventricle is something else. So if you know how you pick up atrial enlargement on the right side, tall P wave. Okay? Now we talk about left atrial enlargement. The P waves will be longer than 0.11, so almost 3 little boxes. So right is height, left is width. Is everybody with me? Height versus width. So we're talking about 2.5 boxes high. We're talking about 2.5 boxes wide, just about. So if it's 2.5 boxes wide, we're talking what type of enlargement? Right or left? Atrium. If it's wide, left. If we're talking about height? Right. Very good. And what we're looking at again? Very good. And what represents atrium on ECG? P wave. Huh? Then you have right and left atrial enlargement. Yep. Oh yeah, absolutely. Yeah. I can't recall, but I'm sure I had patients that probably didn't pick it up. You know, if you're looking for it, you'll find it. You know. So what I worry about more is ventricular enlargement. Because the biggest part with ventricular enlargement is the muscle becomes what? Rigid. And when it's rigid, it can't contract. All right, so let's talk about right ventricular hypertrophy, RVH. Usually caused by pulmonary hypertension. Can you stick a cuff around a pulmonary artery against pressure? No. But you know how you could? If I have right axis deviation, that could be a sign of pulmonary hypertension. All right? So when that pulmonary pressure is high, what will cause pulmonary pressure to be so high? Huh? Take a guess. Think about it. What will make pulmonary pressure high? Why CHF? Yes, okay, very good. Right, so the bottom line is, very good, very good. If my left ventricle is not pumping adequately, the fluid is what? Backing up, increasing pulmonary pressure. So bad ventricle, bad left ventricle can cause pulmonary hypertension and make that right ventricle work harder and create enlargement. I could tell you, how large is that muscle, that right ventricle? How large is that muscle? How big is that muscle? It's not big at all. So pumping under high pressure for a short period of time can cause it to fail because it's not a large muscle that it can work against. So it's easy for the right ventricle to fail because it's not a large muscle. Okay? It's hard for it to work. So pulmonary pressure. So how are we going to determine that? Large R wave in lead 1 and or R wave amplified greater or taller than 5 millimeter QRS, disconcordant, meaning opposite. So the R wave, the QRS and the T wave are opposite. So this is R wave, and then my T wave could be on the opposite. So it's disconcordant, opposite side. Disconcordant just means opposite. Concordant means same. So we're on the same side as concordant. So you see it right there? Do you see the opposite? Do you see the disconcordant, right? Look, once again, I draw, what is this? The isoelectric line, right? R wave QRS is on one side, T wave is on the other. Are we on opposites? We call that disconcordant. Because if we were like this, what would you call this? Concordant, because we're both what? How about this one? Concordant as well, because we both are what? Same side.
Wouldn't that be mistaken for ischemia? 'Cause that's
Could be, but that's why you have the tall R wave, right? Also, do you know peak T's, we call them hyperacute T's, is normally a sign of ischemia and injured tissue. And you normally see that within 5 to 30 minutes of an acute onset of an MI. It's called a hyperacute T. All right, LVH is the big one we worry about. Why LVH is the big one? Why left ventricular hypertrophy is the big one?
that's the big.
Big muscle and pumps to the body, perfuses everybody. So you're going to see that with a tall R wave and a very deep slope S wave, okay? So it looks something like this. So we're talking about the left ventricle. What leads on the 12 lead that look directly into the left ventricle? 4, 5, 6. So what leads would I want to use to determine if I got a tall R wave or not that looks directly at the left ventricle that I'm trying to identify left ventricular hypertrophy? 4, 5, 6, especially 5 and 6. So if you go to 5 and 6 and that R wave is touching 5 boxes or more, I'm talking big boxes, if it's touching 5 big boxes or more, doesn't have to be completely in them, it just has to touch it. So if I got 4 boxes and I'm halfway in another box, is that 5 boxes? Yes. So 5 boxes or more, guess what that means? LVH. And in the slope S wave, patient has left ventricular hypertrophy. Is everybody with me? Okay. Easy to identify. I will tell you, there are 100 ways, and I'm exaggerating with 100, but there's about 5 ways to determine LVH. And every one, but with the one I said, is very complicated. So it could be females, if they have elevation, I believe, of 12 millimeters or more in AVL, and males more than 20 little boxes in AVL, and then have combined with V5, that determine LVH. I mean, it's really complicated. So anyway, that's what we need to know. So LVH, look at 5 and 6. Oh, nice. That's why we can't have, go get some paper too. That's why we can't have nice things here. Hey, throw me that rag right there. Throw me that rag. You good? It's all right. I don't care about your book bag. Drop my floor.
You're talking about the floors where you got 15 copies things?
Yeah. From her, yeah, that one. And you know, if I ban coffee from school, we'll have no stains.
But you also have no
Yeah. So, all right. We can stop. We can pause. What time is it? We'll break for lunch now. Let's move on now. So now we're going to talk about, well, we talked about, first of all, electrophysiology of electrophysiology of 12 lead. Why we do 12 lead, what we're looking for. We're looking at the electrical changes inside the heart. Now we're going to get into what actually takes place. What's the pathophysiology behind it? So what I first want you to understand, I want to draw here a little picture because I'm a kind of an artist, and I like to draw. All right? This is the ventricle. And you know, you have the fluid in the ventricle. And what did I tell you about the coronary arteries? Where are they? Where are they located? On the inside of the heart or the outside? On the outside, right? The arteries are on the outside. Look who came in late, like always, you know. Go figure. You know, at least he's consistent. All right, so that's an artery. Starts from the outside, works his way to the inside, correct? So if I have a blockage, let's say there's a blockage here, the first part or the first place that's going to suffer is the most distal part of that area that that vessel supplies blood to. So which is the endocardium. So always, always, MIs will start at the subendocardium, all the way right here. So what happens is this tissue becomes ischemic. Actually, I should use probably a black marker because it's not good. This tissue becomes ischemic. So what happens to the tissue around it that was positive now has a negative charge. It changes to a negative charge. So what we're going to see when we have our electrode looking in to the Willis central terminal, ST depression, because we see what? A lot of what? Negative tissue. Everybody with me? As this MI starts to grow, and it moves all the way from the endocardium all the way to the epicardium. It went all the way through. We now have what's called a transmural wall MI. Once an MI becomes transmural, you know what we do with this electrode? We see all the way through to the opposite side, where the tissue is good. Positive. So guess what we're going to see? ST elevation. So knowing that, the only time we can see ST elevation is when? When the MI is transmural. So it has to start the endocardium and make its way all the way to the epicardium. If it doesn't start at the endo and make its way to the epi, it's not transmural. So guess what I won't see? Elevation. So if I take this same artery that I drew here and say, you know what, the blockage was over here, will this tissue right here still perfuse? Yeah. So will my MI ever be transmural? So what one thing I won't see? ST elevation, because it has to be transmural. Does everybody understand that? So knowing that, can we ever, all right, before I even get to that, so with this right here, can this tissue die? Yeah. Yes, it can completely die. What do we call that? Infarct. So, can I have an infarction? Can I have a myocardial infarction, an MI, a heart attack, without it being transmural? Yeah. Yes. So what you're saying is I could have a patient who's presenting to me like he's having a heart attack, cool, pale, who's symptomatic, cool, pale, diaphoretic, crushing chest pain, the whole 9 yards. But when I do a 12 lead, I see no ST changes. Does it mean he's not having an MI? It just means to me, it's not what yet? Transmural. So knowing that, we should never, ever rule out an MI pre-hospital. Because we don't know. Because you have to have 2 of the 3 things. 2 of the 3 things have to be positive. 1, am I symptomatic? That's one of them. If I'm symptomatic, cool, pale, diaphoretic, chest pain, I'm symptomatic. Cool. The next 2, all I need is 1 of the 2. Do I have ST elevation? If I don't, then I'm banking on the last one. Positive blood markers. Are we positive for troponin and CPK? If we're not positive for that troponin, we don't take blood markers pre-hospital. So how will we know if they're positive for troponin or not? We won't. So what we should do to all these patients? Treat them as an MI and take them where? To the chest pain center. So we should not be seeing a patient, oh man, cool, pale, diaphoretic, oh my chest hurts, I can't breathe, I got pain down the left arm. You do a 12 lead, says, oh, let's go, you're all right. This is indigestion. This is blah, blah, blah. No, you should never say that. You could treat him as an MI and take him to the appropriate facility. Because you know what that facility is going to do? Draw his blood and wait to see if his blood markers they come back positive. Now, it could take as quick as 6 hours, but it could take up to 24 hours before blood markers change from the onset of symptoms. So guess what this patient is going to stay if he doesn't have a positive ECG that shows ST elevation, but is symptomatic, and he hasn't shown positive on his blood markers yet. Guess where he's staying for 24 hours? The hospital. Why? Because it could take up to 24 hours before you show positive on troponin. So why are we trying to rule these out pre-hospital when we shouldn't? But if he's symptomatic and he has ST elevation, do I need troponin? Yeah, it's probably going to be positive, but do I need that to say, hey, this is an MI? No, because I already know it's what? Transmural. We're good to go.
If it's not transmural, after the heart attack, will you still have the Q wave?
Yes, you can, possibly. Possibly. All right, possibly, absolutely.
So what you're saying is we won't see ST elevation until it's transmural?
Yep. Because the only way you could look through the heart from one side to the other, the MI becomes transmural. The only way it comes transmural, it goes from the endo all the way to the epicardium.
So what's the earliest sign before that happens?
Symptomatic.
Just symptomatic?
Yeah. And if you, as you see to start, well, the earliest sign is this tissue right here becomes ischemic. What happens to this tissue right here? So what are you going to see? So ST depression is the earliest sign of ischemia. We do nothing about it, it's going to turn into what? It's going to spread through the whole wall, then it becomes transmural. So I went from ST depression to now, what? ST depression to now ST elevation. And if you do nothing about it, what's going to happen to that tissue? It's going to infarct. Now it dies. Now I see a pathological Q wave. So you see the evolving process? Now I don't want you to think this is an evolving process that takes over days or hours. This is a rapid evolving process. It could take a couple hours, but it's a rapid evolving process. It can happen that quick in front of your face. You can see depression. You go to baseline with an inverted T, boom, now you got a pathological, now you have ST elevation. Just that quick, okay? But the only way I can determine if the MI is evolving and how quick is by doing what? Multiple 12 leads. So is there such thing as just doing one 12 lead? No, you should have serial 12 leads, yes.
So when you do get the pathological Q wave, do you get them only on the leads that were infarcted, or do you get them on
And the
all
contiguous leads, where the infarction is
you
at.
have an inferior wall and minor
Then you're going to have a pathology, yep.
pathological, and they won't appear like in the anterior septal?
Unless he had anterior septal wall.
Okay.
Yep. Now I will tell you this. What do we do for that?
For what?
Infarcted tissue? What could we do for that?
Nothing.
Nothing. So, if the MI happened 2 minutes ago, if the infarction happened 2 minutes ago or 2 years ago, it don't matter. Why? We can't do nothing about that tissue. So what we worry about? The tissue that is injured, the tissue that's transmural, because you know what I can do with that? Reperfuse and prevent it and stop it from dying. I could reverse that if I start the reperfusion. That make sense? All right?
And when you mean refuse, you mean like cath lab?
No? Dilate the coronary arteries. Can you give nitro? If that can dilate it, does nitro always work? I don't want you to go out there with the misconception, I put a nitro on your tongue, it works 100% of the time. What does nitro do? Vasodilates, especially coronary arteries, right? What's the major cause of heart disease? Very good. Which is? Not plaque. Well, plaque, yes. Plaque buildup creates what? Calcification. What does calcification do to your arteries? Hardens it. Can it dilate? So is nitro going to work on calcification, calcified blocked artery? No. And that's the most common problem. So I want you to know, not all the time will nitro work. Don't put all your eggs in one basket and say, I'm giving you a nitro. You should be feeling better. You are reperfusing. Sign the refusal. Press hard. That's 4 copies.
Somebody once told me that if you give nitro to somebody who has a clot, and it's not related to atherosclerosis, that it can make them worse because it can move the clot.
It's not going to move the clot. If it's stationary clot, it's not moving. All you do is opening the vessel, opening the container.
And it won't push the clot further? Like
Nah. If the clot's going to break off, it's going to break off, whether you dilate the artery or not. It's going to break off and break off. So if it's stationary, it's a thrombus. If it's moving, it's an emboli. Can you dilate an artery, a clot break off? Yeah. Can you not dilate an artery and clot break off? Yeah. So what we do know for certain, if I don't open up that vessel and reperfuse, what's going to happen to that muscle distal to that blockage? Yeah, we know that definite. So that's what we're gearing towards. Does that make sense, guys? But I don't want you to put all your eggs in baskets and put all your eggs in one basket and say, yeah, I'm giving nitro. It's going to work 100% of the time. That's not a true statement. So if I give a nitro and it's not working, I give a second one it's not working, I'm not going to continue giving nitros because it's what? It's not working. What should you be doing? Something else. Look for an alternative. We're going to talk about alternatives and things we can do in a little bit. All right? Everybody with me? So when we talk about injury, infarction, ischemia, it's a process, right? It's a process. It's a process that goes through. I want you to know, though, we have some factors that we take into consideration. I want to know from the onset of symptoms, if this is an MI, that's us, EMS, we have that. I have a time frame that I want this patient in that cath lab. I want this patient in that cath lab as soon as possible. All right, as soon as I could get him. So EMS to balloon time is important. And accredited hospitals who are chest pain accredited institutions, they have to account for these times and all that stuff to the accrediting body to say, hey, are you meeting the credentials? Are you meeting the standards to be a chest pain center? We got a door to balloon. What's door to balloon? The time you hit the back of that ER, the double doors to go in, to the time they get that patient to the cath lab. That's time that they have to account for. And then we have a door to needle time. From the time you hit the door to the time to get thrombolytics on board or fibrinolytics on board. They have to account for that time.
When you refer to that, you mean like the door, like
The hospital. You roll in the back door of the hospital with the patient. Yep. All right? So we need to know that. That's key. So we played a big role with EMS to balloon time. If we never make it to the hospital with the patient, then how we expect them to account for the time and getting them catheterized? We got to take them to the appropriate facility in the appropriate time. So as I mentioned earlier, the ischemic, the injured, the infarction phase, that's a phase it goes through. And it goes in that order. It starts as ischemia, the tissue becomes injured, and the tissue infarcts. Sometimes that process could be so rapid that we miss it. But it is a rapid evolving process. So the key word I want you to take home, the take-home word is rapid. So we understand and we embed that word into our mind that a patient who's presenting to me as an MI, this is a rapid evolving process. What is the most important thing I need to do right away to prevent any further injuries or that tissue dying is what? No. Calling them automatically fixes it? No. What's going to buy this guy some time? Oxygenation, perfusion. I need to get that oxygen beyond that blockage. So how can I get oxygen beyond that blockage? What can make oxygen go beyond a blockage? Open it up. How can you open up an artery? Nitrates, right? Nitrates. Calm the patient down. Why is it so important to keep the patient calm and collective? Because when you're calm and collected, what happens to your heart rate? It slows down. I buy them some time. I don't want the heart to work harder. He can't work as it is, let alone I want him to work harder, because he works harder, he needs more what? More nutrients and oxygen. Are we having a problem with that? Yes, so don't increase the problem. It makes it worse. So am I going to tell this patient, get up and walk to my stretcher? Because walking to my stretcher does what? It increases exertion, which increases heart rate. So my job is to do all that, calm them down, start the reperfusion. But when do I want to start that? Right away. Once I recognize he needs reperfusion, that split second is when I'm starting. I'm not going to say, man, my ambulance is right out front. Let's just run to the ambulance real quick and I'm going to start the reperfusion. No. Or let me put him in a stair chair and a stretcher, then we'll start the reperfusion in the back of my ambulance. Can a lot go wrong between there and your vehicle? Yeah. Maybe I got delayed. Maybe that door didn't open up the way it opened. I got to go around the long way. Now wait to get to the hospital, to the back of the ambulance. That 5 minutes, 2 minutes, 10 minutes you took to get to your vehicle was the difference of this patient coding. But if you would have said initially, I recognize it and start the reperfusion right there, things would have been different. You with me? All right. So those are things that we want to do. We need to start it immediately. I can't emphasize that. I can't emphasize that enough, that we got to start reperfusion immediately. All right? And the reason why, what's the take home? What's the concept? And that's the key, guys. When we start testing for national registry, what is the concept? What's the core concept there? Why is it so important for me to understand I need to start the reperfusion right then and there? Because that tissue is lacking oxygen. And what did I tell you about MIs? They are a rapid evolving process. I can see ischemia right here. And when I get to that vehicle, now it's infarcted tissue. I missed the concept. I missed the reason why we start the reperfusion early. But if I would have started the reperfusion right here, gave nitro, did aspirin, do all that, give him Hycon O2, give him all that stuff that I need to give him, and now oxygen's passing through, now we transport, what's the likelihood of my tissue dying? Unlikely, because I start the reperfusion. Sometimes they'd be asymptomatic. I had a lady I picked up at Bonefish Grill by the airport. Everybody familiar with the Bonefish Grill over there? At the airport, it was like 10, 11 o'clock at night. It was at the end of the day. At the end of the day, syncopal episode, only complaint. We get there, syncopal episode, cool, pale, clammy. She looked at cool, pale, clammy. She looked at sick. We got in the back of the rig. We started reperfusion. We got in the back of the rig. We got, it looked like she was, they wasn't sure it was an MI or not. I was like, it looks like an MI, you know, whatever. Let's start the reperfusion. Got in the back of the rig, reperfusing this lady, giving nitros, the aspirin, the whole 9 yards. Got on oxygen. Lady, by the time I got to ORMC, this lady was asymptomatic. Her skin color came back. She was very vibrant. She was up because she was very lethargic, very sluggish when we got there. Now she was up, clear, cool. She was no longer cool, pale, diaphoretic. She was pink, dried up, looked great, like nothing was wrong. We opened the hospital. I called it a STEMI. We opened the hospital. Doc's like, he didn't want to call it a STEMI. So he's consulting with his other doc. What do you think? So I listened to him. I'm wheeling my stretcher over to hear their conversation so I could charm in the conversation. And long story short, they didn't want to call it STEMI. So I said, well, I was taught I should do what for my patient? Advocate. I said, Doc, I can help her over here. You're not calling this a STEMI. Of course, I wheeled my stretcher, so cleaning it while I can get closer to hear the conversation because I couldn't really hear it. So I said, hey, I could have stopped but overhear your conversation. You're not going to call this lady a STEMI I brought in? He was like, no. He says, no, I'm going to call her. EKG looks good. Look at her. She looks fantastic. I said, but you should have seen her when I picked her up. She looked nothing like that. And I started the reperfusion. Is there a possibility? I'm no doctor, but is there a possibility that I was able to reperfuse and now she's doing what she needs to do? Could it be that the medication dilate the artery enough where it could reperfuse if she's asymptomatic? He was like, yeah. So the other doctor, I knew the doc, by the way, too. There's one doctor, one of the doctors. We're doing a research project. So I was like, come on, Chris, you got to call this lady a STEMI. So the other doc was like, well, who's this moron telling you what to do? You're the doctor. He was like, no, I know this guy. He's pretty good with his patients. He advocates, gets himself in trouble all the time. So anyway, I was like, all right. I said, look, man, I presented again. Look, ECG showed elevation. Remember, she's a female. She's atypical. A lot of females don't have chest pain. Their common complaint at MI is a syncopal episode and fatigue, and she had all this. This is it, man. This is the one we're going to miss. We're going to miss this one if we don't take it to the cath lab. And he was like, man, get out of here. So I started walking away. Then I made a U-turn because I couldn't walk away because my body's like, yo, just go. And then my brain, my mind was saying, just leave. And my heart was saying, that's not right, man. So I started walking away. So my brain is fighting with my heart, right? My moral. So I was like, you know what? Go ask for forgiveness later. I walked back. I said, look, Dr. Vu, with all due respect, you're in your last year of residency, I believe, right? He was like, yeah. I said, well, I've been a paramedic for over 20-something years. Can I get some credibility? All I'm saying is my instinct is telling me this is an MI. 20-plus years of instinct is telling me this is an MI. 3 years of residency is telling you it's not. Do the math. I got this feeling. It's really, I'm telling you, the feeling is so strong, it's making it hard for me to walk out this ER. I'm about to get in trouble with my medical director because we're having this conversation, and probably my supervisor, because you're going to call and complain about me. And I just want to advocate for my patient. He was like, get your butt out of there, my ER. It's like, okay. I'm not feeling good about this one. I'm screaming all the way out that ER. So I'm not feeling good about this one. And I walked out, cleaning my stretcher, finishing up, packaging up. a tech comes out and says, hey, Dr. Vu said, give him your EKG. If your first EKG shows elevation, he's going to call a STEMI on your gut feeling. And he said, you better be right. So I cut it off, printed out, ran inside, excited. I cut the first one, I cut it in half. I ripped the whole thing off. Besides, I printed it again, cut out, go in. So Dr. Vu, look, let me show you just in case. Elevation right here, this is my first one. You see the reperfusion. Remember, he was like, all right, I'm calling it. He was like, Felix, I swear you better be right on this one. I said, I'm 100%. I'm almost 100% right on this one. I threw the almost in there as a disclosure. So he was like, all right. So anyway, I left. I was like, well, I hope I was right on this one. If not, I won't be able to go to RMC no more. Well, as long as Dr. Vu was there. So anyway, weeks passed. I forgot about it. Whatever. We're finishing up a project because I was working on a project with him, Dr. Baker, Dr. Hunter, a few docs were doing this STEMI project. Actually, it was funny. The pit crew methodology, we were doing a study on that. So he came in, he was like, oh, I forgot to tell you. I was like, hey, what's up? He was like, hey, remember that lady that you were a a-hole about? I was like, a a-hole? I'm offended by that. I was advocating for the lady. He was like, yeah, whatever. He was like, the syncopal, remember you was being, I was like, yeah, I remember. You don't have to remind me. I apologize to Master. I didn't mean to insult you. That wasn't my intent. He was like, no, you didn't insult me at all. He was like, but that lady you did? I said, did she have an MI? He was like, she had a massive blockage. She had 3 blockages. She had a 98% blockage on her LAD, and I think it was like 80% on her circumflex. She was like, this lady was a ticking time bomb. He was like, thanks for advocating and pushing for that patient, but I will tell you this, don't ever push again like that to me. I was like, all right, cool. So anyway, he called, he was like, but lesson learned from me. He said, you know what he told me? He says, lesson learned from him. He says, you know what, sometimes you got to listen when people talk to you. And I was looking at a patient, not listening to what you were telling me on how to present it. So that's where I get into, and that I share that story. It was a great story because it obviously favored the right way that I wanted to. But if not, I would have never told you the story. But the key thing the take home of that story is, what was I able to do? Rapidly reperfuse. Reperfuse so good that she became what? Asymptomatic.
Wouldn't you have advocated better if you wouldn't have refused and then
No,
asymptomatic? And
I was waiting for somebody to say that.
Into the cath lab a lot faster. And got an
But then you say yourself, did you do your job?
well, no, not really. But
So you.
not
No?
really.
Well, I see what you're saying, and that's valid. That's a valid point. Maybe I shouldn't have reperfused so I could bring it into the ER looking like she. But then what happens? What's my job? What's my job there to start the what? Reperfuse. If I didn't reperfuse, she could have died, right? I would have presented her as a code, but maybe that would have pushed the edge that she wouldn't be able to resuscitate. You know, a fireman just passed away, right? Joe, you heard? Joe was one of my students. He graduated from OMI. He's a fireman at Claremont. He graduated from here, OMI. And Joe DeMarisi, he had abdominal pain. He had abdominal pain, doesn't feel right, went to the hospital. He went to the hospital, and they put him in a room. And he was nauseated and feel good. And he was like, you know, because he told his wife, because he went home sick. And he went home and told his wife, I feel good. Long story short, just took him to the hospital, went to the hospital, put him in a room. He was in a room for a while. I think almost 2 hours or something like that. And then you know when they took care of him? When he got up to the sink to do whatever, he passed out. Throw him on there, the EKG, massive MI, he was in VTAC. He was in VTAC for 14 hours. They had to fly him out. They flew him from Sand Lake, not Sand Lake, what's the hospital up there in Claremont? South Lake. They flew him to ORMC. They finally broke him out of VTAC, and then they realized he lost his whole complete ventricle. Left ventricle was at less than 10% ejection factor. That they stabilized him, and they were flying him straight to Shands for a heart transplant, immediate heart transplant. When the helicopter's on the way, he died. Couldn't bring him back. So we're talking hours of delay because of that. Could it have been a different story? Who knows?
You can picture that too, because you go into the ER with abdominal pain, they're gonna be like, yeah, here's a bark bag, go sit down in the room.
Mhm.
You're supposed to do what you can't do though.
They
Every
s-
now and then you
it's sometimes things slip through, you know. It's about, we gotta get, this starts with us as healthcare providers. And this is what I'm telling, this is my story here, Julia. My story is, if you don't advocate for your patient because what you believe is going on, then who is? And that's just what I did. If somebody advocated for him, maybe something would be different. But you could do all you could do. But advocate. If you think it is what it is, then push it. Do a 12 lead. Because if you would have took and done a 12 lead on him, and it would have showed an MI, how you argue that? If you say, oh, this is indigestion, then what are they going to treat it as? Indigestion. So it comes back to, we got to get out the mindset, and this starts with us, that MIs are not a geriatric disease. Because that's what we believe.
How old is he?
32? 32 years old? It's not a geriatric disease. But I'll tell you that today. I'll tell you that tomorrow. I'll tell you that next week. And then I'll tell you that today. You go work tonight, you get the 30-year-old that had chest pain, and you're like, BS. You didn't get there yet, but it's BS. But if you had the same call, chest pain, and he's 90 years old, ooh, this could be an MI. This is a good one. We're being biased with the disease. And there's a lot of young people that die every day from a heart attack, and they're young, under 50 years of age. So get away from the discrimination. If I got pain from the navel to the nasal, I'm going to do a 12 lead. I'm going to do an assessment. Syncopal episode, all my syncopal episodes get a 12 lead. Because syncopal episodes are common in 12 lead. You know what syncopal episodes common in? Women, diabetics. And you know who else is a critical patient? We're going to talk about it a little bit. But a patient who syncopized, and I did a 12 lead, and he has Brugada syndrome, that dude, it got 1 foot in the grave, and he's slipping on a banana peel. And if you don't recognize that Brugada, and he's syncopized, that's a guy that I got to go to a chest pain center. When? Scotty beamed me up 2 minutes ago. But if you don't syncopal episode, everybody gets 12 lead. I don't care. Unless you could tell me somebody said boo, and you fell out and you woke up, then I might accept that one because somebody scared the crap out of you and you passed out. Okay. Other than that, what does it hurt you? Does it take up all your time to do a 12 lead? No. You know what it takes me to do? My EMT, hey, do me a favor, do a 12 lead. That's what it takes. Right? So what I'm getting at is if you believe it's an MI, the hospital is going to treat it as so. If you don't believe it is, and you want to convince yourself it's an indigestion, then convince yourself, and that's what the hospital is going to treat it as. And that's the ones we miss. Okay? So it's a rapid evolving process. So we know where we start with. The MI starts with what? ST what? Depression. I'm sorry. Yeah, ST depression. And then it rapidly evolves into inverted T wave. Why it goes to that? Because what's happening to this J point? It's starting to elevate. I just happened to catch it when it's back down to what? I got it when it's back up to baseline. But you see it right here? It's just pulling it up. So that's a sign of ischemia as well. So I go from ischemia now to elevation. Elevation means now I went from ischemic tissue to injured tissue. From injured tissue, I now go to, actually it's more like, to what? Dead tissue, because this Q wave is at least 1/3 the size of the R wave. Would you agree? It's bigger than that, right? Or my Q wave is at least one little box or greater in width. That's also considered pathological Q. So what does that mean? The tissue just what? Infarcted, dead. What does this mean? Dead tissue and What's around that dead tissue? Dying tissue, right? Injured tissue. We call that critical? Yeah, that's worse, right? So, what you going to do? Say it again?
Get them to the hospital as fast as you can.
Transport.
Thank you. We're going to start the reperfusion and get them to the hospital as quickly as we can. But what we're going to do first? Reperfuse. I want to get you to the hospital as quickly as I can, but the quickest I can get you there is an hour. But all in all is, can you start the reperfusion? Yes, so you need to. All right? So Q wave, we just talked about what the Q wave is, all right? We look at the ST segment. We want to know if it's below the isoelectric line. If it's below the isoelectric line, that ST segment, we call that ST depression. If that ST segment is above the isoelectric line, we call that ST elevation. All right? Very good. All right, so, yes.
How do you call it a radio report, like ST depression? Just like
I would call, the age, the name, all that stuff, and I'll just say, 25-year-old male complaining of substance, or 25-year-old STEMI alert showing ST elevation in 2-3 AVF. Anytime having a favorite wall with elevation in 2-3 AVF, blah, blah, blah. And tell them everything you've done.
But the depression, you won't call anything on it?
Why? It's a STEMI. Yeah, I'm good. It's a STEMI. Elevation. That worse than depression?
Yeah.
Yeah, that's what we call it. Now, if it's just depression,
That's right.
all you see depression, and I call it a cardiac. I got a cardiac patient, medical yellow, medical red. I can't call it a STEMI? No. What does STEMI stand for? ST elevation myocardial infarction. There's no elevation. Why? It's not transmural yet. But he'll be treated. And what hospital would you take him to? Cardiac facility. I would still take him to a cardiac facility because he's going to need to see a cardiac person. Right? Make sense? All right. So, the T wave is the most dynamic wave. You know what they mean? It's constantly going different ways on the isoelectric line, right? It's downwards when it comes to ischemia. Then it could be upwards. Then it could be downwards here. It's normally upwards, so it's very dynamic. And as I mentioned earlier, patients who are having MIs, especially in the anterior wall, anterior muscle, they'll normally have what's called a hyper-QT syndrome, or hyper-QT, I should say. It's not a syndrome, but hyper-QT. And what that is a very peak T. And that happens within the first 5 to 30 minutes of the onset of symptoms. So if you see that hyper-Q, it's hyper-T, I should say, hyper-QT, you see that hyper-acute T is what I'm trying to say. I don't know if I'm saying hyper-acute T or whatever, but hyper-acute T, meaning a high, acute, suddenly peak T wave could be a sign of an MI. All right? So, never rule that out. The TP segment, period of electrical silence, right? So, the electrical silence in between that T wave and the next P wave, it helps us with the rate. The longer that is, the slower the rate is. The tighter it is, the faster the rate is, okay? All right, so ischemia, as I mentioned, starts from endocardium and works its way through and is represented with ST depression and or an inverted T wave, okay? As it moves on to injury, is now going to have ST elevation. Once again, ST elevation can only be seen if transmural. Very good. Which means? So from the endo all the way to the epi. Very good. Now, we have what's called reciprocal changes. Anybody know what reciprocal changes is? What's reciprocal change? Who can tell me? Well, we don't move no leads, but kind of on track. Yeah, you're kind of on track. Right. Very good. You're going to see the opposite deflection. I know. I figured that. So, no, I know you was on en route there. Just need a little help. No biggie. All right. So we have the right coronary artery, right? We have the left coronary artery in the circumflex, right? Right? So, right left. So if I have a blockage here, it's going to jack up my leads right here, right? So this is what artery? Right. What I'm going to have here? Elevation. So what I have here, I should see on the opposite side, the opposite deflection, to call it reciprocal. So what are we seeing? Elevation. What's the opposite of elevation? What's the opposite of right? Left. So AVL and the AVL lead 1, we should see what?
So would you say that's where it started?
No, that's reciprocal. Get the mirror image. It's going to show a mirror image because we're talking about electricity.
Right,
So-
but in the beginning you said depression was the
Right. That's depression. We're not calling that depression. We're calling that reciprocal. So reciprocal changes helps me identify that this is true ST elevation. Oops. This is true ST elevation. So there are mimics out there we're going to talk about. There are things that will mimic ST elevation. You'd be like, man, is that ST elevation from an MI? Or is that ST elevation from early repolarization? I don't know, because they almost look the same. So what can I do? Look at the opposite side to see if I have what? If I have depression on the opposite side where I have the elevation, that's reciprocal changes. Then that just solidifies to me that that ST elevation is true ST elevation, that is secondary from injured tissue. It's not a mimic. You with me?
Yeah.
Everybody with me?
So maybe what you're saying is if it's just depression,
If it's just depression, no elevation, that could be ischemia, yeah.
elevation, and you also see depression, it's just
Reciprocal. You with me? You got it. I think you got it. How about if I have elevation in my lateral leads? Where I see reciprocal? What's the opposite of left? So where I see it? Inferior wall. Right? It's the right side. Everybody with me? V1, V2 looks at what part of the heart? The front. Septal, right? Front. That's where the septal sits, in the front. So if I have depression in 1 and 2, can that be reciprocal?
Yeah.
To what?
Posterior.
Posterior. So if I got depression 1 and 2, it would prompt me to put leads in the back to see if I have what?
ST elevation.
If I don't have ST elevation, then what would that be?
it would be
See, that's what I was.
It would be ischemia. So it moves it back. How about if I have, well, we don't normally do back, but if I did the back, where would I see my reciprocal? And the anterior leads. But we normally do the other way around. If I have depression here, I'll prompt me to go to the back to say, hey, this could be reciprocal. Make sense? That's what reciprocal changes is. So reciprocal changes truly helps me identify, is this true ST elevation or not? I don't want to be caught with my pants down.
you take 1 and 2 and put it on the back on either side of the spine.
You can, but I always leave 1 and 2. I'll just grab right here. I'll grab 3, 4, 5, put it to the back.
And would that be 7, 8, 9?
Yep.
See the back
Mhm.
side of the
Yep.
sternum?
And we call it 789 because it's down on the sheet. And make sure we mark that paper 789. That tells me I move those 3 to the back.
And that gives you that posterior.
Yep, and if I have elevation, then that septal wall was true reciprocal changes. So that's a true posterior wall MI. Make sense?
So it's just to consider it extending. You have to have both sides to confirm it.
No. You call it ST, but if you question it, reciprocal. But all ST elevation that are injured will have reciprocal change outside. So you should always get in the habit of look for reciprocal changes to confirm. All it is confirmation. You should know how to read ECG, but it's just confirmation. All right?
What artery would that be if you got a posterior MI?
That could be, there's a marginal artery, it could be part of the circumflex, it whips around, it could be somewhat of the right because it could come up. So there's multiple arteries that come to the back of the thing. But like I said, we want to beat them up. The marginal will probably be one, the main one that goes around the back. But we don't even use it, posterior walls count for less than 3% of the MIs. If you ever seen a heart, anybody ever seen a heart be dissected, taken out?
I was gonna go see one of your dad on that.
We got one August 2nd coming up. August 2nd, Gainesville. Sign up. Go teleflex.com, go on there under events, go to the events, look for the cadaver lab, Gainesville, August 2nd, sign up, free lab. I'm trying to bring one here to the school towards the after the summer. I'll let you know when they let me know. I requested it already. But I'll pull out the heart and I'll show you. But if you look at the heart, take it out, all the fat's on the front. There's little to no fat on the back of the heart. All the fat lies on the front of the heart.
Why is that?
You know? I don't know. All right, let's take a 5-minute break. When do we do a right side ECG? Who remembers? When we move V4 to the right side? When we have an inferior wall MI. When that inferior wall MI, when we have an inferior wall MI and the blood pressure is borderline low, okay? Because we want to see if the right ventricle is involved. If the right ventricle is involved, what could we do to get that pressure up? Fluid, very good. And then once the fluid's up, that blood pressure's up, what can I give this patient at this time? Nitro. Do I want to give nitro with a low blood pressure? No. So before you give nitro, I do a V4R, confirm. And if it's involved, before I give nitro, I make sure IV is established so I can give fluid. If I can't get an IV, then I'm going to give the nitro? No, I got to make sure the IV is established. Because if that pressure drops, I could give a fluid challenge, or I could give a fluid challenge before I give the nitro. And if the blood pressure drops again after nitro, what can I do? Another fluid challenge. And pressure's back to normal. The key thing is, what do I have on board now? Nitro to open up those arteries. Okay? Now, we tell you in EMT school, right? It's contraindicated with low blood pressure below 100, right? But in paramedic, we won't tell you it's contraindicated. We'll tell you take precaution. Because we need to do what first? Start the IV. All right? All right, we talked about reciprocal changes. So if I have elevation 2, 3 AVF and lead 1 in AVR, should have reciprocal. If I have elevation 2, 3 AVF, I could also have reciprocal 1 through 3 and blah, blah, blah we just talked about. All right. You know what? I want to take away, okay. What we're going to do is stop recording. I'm going to bring up, more in depth than the other one I did, the one I did at the presentation.
Oh, okay.
So right axis deviation, if you want to know what causes right axis deviation, these are some of the things that causes it. Okay? So,
It's not treatable though?
yeah, treatable. All right, so a well-perfused septal wall. A well-perfused septal wall, if you look at my picture up here, so when you see it, the next couple, and this is the electro, and it's looking right through the heart. So you can see the endocardium, the myocardium, the epicardium is perfused. You see the artery comes from the outside, works its way in. So this is a well-perfused heart. Looks good. Now, what would I see? A normal ECG, or what some people like to call it, what you should call it, is non-diagnostic. But now we have ischemic. Once the tissue becomes ischemic, we have a blockage of the coronary artery. The tissue now becomes ischemic. We have inadequate tissue perfusion. It always starts at the subendocardium, as we talked about. And it's going to be represented, the ischemia, by ST depression or a inverted T wave. May or may not result in an infarction. If we start the reperfusion and we're successful, then we prevent the infarction. So here you go. What happens? We look at the electro right into it. You see at the endocardium where the tissue now becomes ischemic. What we're going to see? ST depression. As ST depression, you can see right here, you see depression. What lead is this? 2. We got depression here. We got depression here, right? So what kind of MI is this? Inferior. So if I have depression here, how can I confirm? Actually, yeah, I could confirm it's depression. Never mind. I was going to say how to confirm is elevation, but that's ST depression. Never mind. See depression all through there. All right, injured tissue. If the tissue is injured, it's prolonged ischemia. After a while, nobody started the reperfusion. The tissue went from ischemia and now became injured. So once it becomes transmural, there we'll see the ST elevation. Usually results in an MI if, once again, we don't start the reperfusion. And here you go. As you can see, you look through the tissue, it's all the way through, it's transmural, and you can see the opposite side where the tissue is good, and that's where you get the ST elevation. All right, so see the elevation? Easy to identify, right? Now let me go back one. Elevation. So if this is true ST elevation, what should I see on the opposite side? What's the opposite side? So I got the pressure here?
Yeah.
Do I got the pressure here?
Yeah.
Yep. So is that true ST elevation?
Yeah.
Yes, it is. So infarction is dead tissue. Tissue is dead. What can we do for infarcted tissue? Nothing. It's dead. Represented by a Q wave. All right. Non-infarction. Not all infarctions develop a pathological Q wave. So, but for the majority, you'll see that. Okay. So you can see where tissue is dead. What can we do for this tissue? Nothing, as I mentioned. So we talk about reciprocal changes. Reciprocal changes are important to identify because that's going to help us identify if this is true ST elevation. So ST elevation in contiguous leads most often represented by acute infarction. In acute infarction, ST elevation in contiguous leads is going to coupled with reciprocal ST changes of depression in the opposite side of the opposite leads to let us know that this is evident that this is ST elevation. So you can see here, do I have elevation? Yes. So I got depression, I got depression. So I have reciprocal changes. So ST elevation, ST depression. All right. Let's identify the different MIs we talked about. Sally, right? So septal. We know lead 1, lead 2 looks at the septal wall. So we look at my camera right there, it's looking at the front of the heart, right where the septal sits. All right? So we got V1, V2 that sits on the lateral side of the sternum. V3, V4 looks at the anterior heart wall from the left anterior chest. So from left side to there. As the entire lateral wall is 1 AVL 5 and 6, it looks at the lateral wall of the heart from two different perspectives. What are two different perspectives? Well, we got two leads, one in AVL that looks at the heart from a vertical view. Then you got 5 and 6 that looks at the heart from a horizontal. So those are two perspectives we're referring to. Does everybody understand that? Okay. So if we look at 5 and 6 by itself, it does look at the lateral wall, and that is two contiguous leads. So if I have elevation just in 5 and 6, then what we have is a low lateral wall MI. Because if it's 1 in AVL, we're talking a high lateral wall MI. All right, inferior wall looks from the bottom up. Okay, as you can see the camera, let's look at the bottom of the heart. That's 2, 3 AVF for the inferior wall. Sally, as I mentioned, septal anterior lateral inferior wall. As we know, septal anterior lateral deals with the left coronary artery, as the inferior wall is the right coronary artery. All right. AVR. Somebody asked me that today. Oh, she's not here. She had to leave. Oh, she's going to miss the knowledge. AVR is referred to as the forgotten lead. We don't use it. You know why we don't use AVR? No? Why we don't use AVR? Anybody know? Anybody take a guess?
I know why.
What's the rule behind ECGs? Two contiguous leads. Who's contiguous with AVR? No one. He's by himself.
But didn't the Chinese do the looking down straight?
That's pretty biased, bro. Because China's underneath us?
I just go with the instructor.
All right. AVR is a lead by itself. That's why we haven't used it. Does it mean that you can't have an MI and have elevation in AVR? Absolutely not. So we call it the forgotten lead. So I'm here to tell you that on ECGs, AVR has traditionally received less attention in clinical evaluation. Then why don't we call it a 11 lead? Why we call it 12 lead? We don't use it because technically all we use is 11 leads out of the 12. So I will tell you, if you have ST elevation in AVR, you have an 88% chance that you have left main coronary artery blockage, that the left main coronary artery is blocked. Left main coronary artery. That is a main artery that supplies what? The whole left side. 43% deals with blockage, a high blockage, that would be a high occlusion of the left anterior descending. Only less than 8% deals with the right coronary artery.
And then that's a high. ECG. There are other signs for that, right? Besides
Maybe cool, pale, diaphoretic, chest pain, all the regular classic signs. You look at AVR and you see elevation.
would you see it anywhere else on the 12 lead besides the
No.
So that could be possibly your
Well, can you see what elevation? Yes. You can see a whole anterior lateral wall in mine. It's a possibility. But AVR, I know it's high up in the left main coronary artery. So if I got elevation in my arterial septal and in AVR, I know that blockage is high up in the left coronary, left main coronary artery.
So but you said earlier that we need to
Yes,
classify as a STEMI,
correct.
but that's one.
That's one box. This is one lead, not one box.
One lead.
So that's why I'm here to tell you that there's new information that's out that says if you have elevation in AVR, you have an 80% chance it could be left main. So you could call it. Say, hey, I'm calling a STEMI based on elevation in AVR, possibly can involve the left main coronary artery. Can you do that? Sure. They know what you're talking about. And they understand that's the lead by itself. Okay? Is everybody with me so far? So, however, ST elevation AVR is not entirely specific to left main coronary arteries. I just mentioned. Can I have a anterior lateral? Yes. All right? It also has been proven that you can have proximal, which is high up, left anterior descending blockage, triple VD, which is the triple vessel disease. What are the triple vessels? 1, 2, 3. Triple vessel disease, okay? Or diffuse subendocardial ischemia. So all those things could be proven as well in our AVR, okay? So we have this criteria called Scarbosa. Dr. Scarbosa came out with this criteria quite a few years ago, and the criteria is based for it's a criteria of a study that was done only on left bundle branch blocks and ventricular pace rhythms. Because prior to Dr. Scarbosa, guys, we weren't able to read ST elevation or call a STEMI if it was an old left bundle branch block or if the patient had a ventricular pacer. We used to call those mimics. So you looked at 12 lead, you look, you see you have a left bundle branch block, you talk to the patient, he says yes, he has a history of it. Because he has a history of it, we couldn't call it a STEMI. The same thing with the ventricular pacer. So Dr. Scarbosa came up with this criteria. This criteria measures 3 segments. They say if you have any one of these 3, you have a high chance of it being a STEMI. So what's the first criteria? Well, before I get to the first criteria, he used 2 things to determine this: concordant and disconcordant. Concordant means on the same side as we talked about earlier, and disconcordant means not on the same side, which would be the opposite side. So it says if you have ST elevation of 1 millimeter in a lead with positive QRS and it's concordant, it counted for 5 points. What he's saying looks like this. And why QRS and where's my ST segment? They both on what? The same side of the isoelectric line. They say if you had that with just 1 millimeter or more, with a left bundle branch block or ventricular pacer, that was a STEMI. You could call that a STEMI. Does everybody understand that? If I had ST depression and my QRS on the same side, are we on the same side? So that's also what? Anybody? Concordant. So since they're both concordant and they're 1 millimeter more, they both weigh at 5 points. That one weighed at 3 points. 5 points was the first one, elevation. This weighed at 3 points. But it said if it's 3 points or more, it was actually a high index, a 90% chance it was an MI. All right? And then this concordant, which would be this one.
That one going down is representing the left bundle? Or is it just...
Yes, it could be, or a ventricular pacer. There's a spike there in a white QRS. It could be the same thing. See this concordant? So where's my QRS at? Predominantly on the bottom, and my ST segment is on top. So we're on opposite sides of the isoelectric line. That's disconcordant. If that's 5 boxes or more, that's a STEMI. Now, nope, there goes a picture of it. So the first one is concordant, second one's concordant, and the last one is disconcordant. For your video? Then move. Then move.
All right, you did.
Could you go back to slide one second?
Yes, I can. Now,
This will be online, right?
online, yeah, that's the PowerPoint I just put up. It's all there. Same slides, me lecturing it again. All right, so here, and I think I go into detail as well. This is the original Scarbosa criteria. They just recently modified it. So they said if you meet any one of these three, you have a 90% chance of it being an MI. Now, they modified it, and what they said is, yes, it still applies to a left bundle branch block and a ventricular pacer, right? But it's saying that they validated two of the three. The elevation, both the two concordants have been validated, so that's 90%. The third one has not been validated yet. The disconcordant has not been validated. And because of that, this is what we're looking at. So actually, just going through it again. It's showing this concordant ST elevation, 1 millimeter more. We talked about that. As concordant again, as 1 millimeter more, both on the same size in my V leads. Disconcordant, 5 millimeters or more. But what it's saying, though, is if you score 3 or higher, which the first two that were validated scored 3, one scored 5, they say you have a 90% chance that this is a STEMI. So if I had a patient with a left bundle branch block or a ventricular pacer that met any one of those two criteria, their chance of having MI is 90%. Is those good odds? I'll take 90% any day in Vegas. All right?
Question-wise, just with the left bundle branch and the ventricular pacemaker, why isn't it, where's the right bundle branch?
It didn't. Right bundle branch, you can still read your ECG. You just struggle to read ST elevation in V1 to V3, anterior septal. But you can look for lateral, you can look for inferior. But when you talk about the disconcordant, it has not yet been validated, but it says if you have a disconcordant, it's only 50% chance. That's the new modification. But I don't know. 50%? That's good odds for me. Especially if I'm on the recipient end of that. I'm the patient. Well, you get a 50%, sir, that this could be an MI, but there's a 50% chance that it's not. So do you want me to just take you to Centric Care, or would you like to go to the chest pain center? 50-50, what are you weighing in? Chest pain center, right? Make sense? I like odds. 50-50 in roulette, it's phenomenal. What do you think everybody bets? On the black or red? 50-50. All right, mimics. We have what's called mimics. Mimics are ECGs, things or diseases that can mimic ST elevation. So something that can mimic ST elevation. So left bundle branch can mimic. Thank God for what? Scarbosa. Because without Scarbosa, prior to Scarbosa, it was just a mimic. If somebody had an old left bundle branch block, you couldn't look for ST elevation. Done. You couldn't call it a STEMI. You could just take them to the hospital as a cardiac red, cardiac yellow, and that's it. Now you can call it a STEMI if they meet the Scarbosa criteria. But let me tell you the significance of this left bundle branch block, how important it is. Well, we got to be able to identify. Remember I tell you about the turn signal theory, right? Turn the ECG clockwise. Whichever way V1 is pointing, that's the block you have. Like this. Right versus left. Everybody good? So look at this. This is important right here. This is what I want to take home. That left bundle branch can mimic acute coronary syndrome. And it accounts for 67% of associated with pump failure. Left bundle branch blocks that happen, 60 to 70% of those left bundle branch blocks were associated with pump failure. As 40 to 60, the mortality without perfusion. It's crazy. People with left bundle branch blocks will die. So left bundle branch block could produce ST elevation, ST depression, to T waves, inverted T wave. It could also hide the same thing. So we use the Scarbosa criteria to analyze that. All right, so how we recognize bundle branch block? Who remembers? Go to lead 1. Is it wide in lead 1? So what we do next? Down, up or down? So it's a what? Left bundle branch block. Very good. Left ventricular hypertrophy. We talked about this, right? Now, I want you to see the different ways, the 4 different ways you could read left ventricular hypertrophy. Let's go through these. The Cornell criteria. Add the R wave in AVL and in the S wave in V3. If it sums up to 28 little boxes in males, LVH. If it sums up 20 millimeters or more in females, LVH. It's a pain in the butt. Then they modified it. They did away with the girl and the guy. They said if you have an R wave in AVL, if the R wave is greater than 12 millimeters, then it's LVH. Done. Early repolarization. Talked about that too, right? Common in what patient? Young, under 50. Less common, over 50. Very rare in 70s. Is everybody with me so far? All right. Early repolarization. Oh, man. Need some coffee. Early repolarization, you're going to see a concave ST elevation. This is a mimic, guys. Early repolarization means, so I fired depolarization of the atriums. Pause. I've depolarized the ventricles. Now, pause. Now they repolarize. Everybody with me? What early repo is, fire. Come. It should be repolarizing, but should be slight delay, then it repolarizes. So there's no delay. It goes right into repolarization. This slight pause doesn't happen. It goes right into the T wave, right off the S wave. So what does that look like? ST elevation. But the difference is it's concaved, and you get the S wave that comes down. So if you know about concave or convex, that's convex, concave. If I had a beer and I poured it out, what will happen to the floor? It'll stay in there. Versus if I put the beer here, it'll roll down. See? He smiles because now he got it. He's like, oh, why did you just say that? I got it.
It just went off, right?
Yeah.
No, it's just a funny analogy.
All right. So, and one thing with early repolarization, guess what you're not going to see? Reciprocal changes. So here we have the different ways you can see early repo. So if everything from the notching to the smiley face, the J hook, everything you need. So look, if I had early repo, draw a circle, finish the happy face and 2 eyes. If you can do that, you have early repolarization. All right? So everybody see the notching? The notching is probably the hard one to find. This is the notching right there. See that little notch? You'll see that. And then it's what? Concave. Or you can see the S wave come down, go back up, and then fish hook. This is a fish hook too, by the way. Huh? What was that? You guys Snapchatting each other back and forth, man? You guys in love or something? So look, who's repolarizing early? Who is repolarizing early? Okay. QR with patience. The QRS depolarized, right? After the QRS depolarizes, or the ventricles depolarize, what they do? The ventricles repolarize. Freaking patient. Where? So what leads look directly into the ventricle?
4, 5.
So that's where you'll see the repolarization, early repo. So if you look right here, you see it. Pericarditis. Anybody ever heard of that? Pericarditis is inflammation of the pericardium. So what causes pericarditis? Most of the time it's an infection. So a patient who is suffering from the flu or a chest infection will probably get pericarditis. Not say probably, they might get pericarditis. All right? So we got to get a history to find out what's the deal with that. That's pericarditis. The key thing with pericarditis, you're going to see elevation all over the place. All over. It looks like a septo-anterior lateral inferior wall MI, which is not. And secondly, not only do I have elevation all over the place, it's concaved. But I know it's not early repo because it's more than the ventricles that are showing. So when you see ST elevation all over the place and it's concave, I talk to my patients and say, hey, you been sick with the cold or the flu or a chest infection? Yep, I had the flu for 3 weeks. Okay, that makes sense. All right, Brugada. Sorry. We kind of talked about Brugada a little bit, right? What did I tell you about Brugada? I didn't tell you how to find it, but what I told you is important about somebody with Brugada syndrome.
Single episode, probably that.
Yep. Single episode, serious issues. So Brugada came up by the doctors, 2 doctors, they're brothers. They're from Spain, I believe. Spaniards. They came up and they recognized their Brugada syndrome. So what is Brugada? Many people have Brugada syndrome undiagnosed and probably never know until unless you had a patient who stubbed his toe or banged his knee and something told you to do a 12 lead. And you did a 12 lead, boom, and you found it. But what's key with this is people with Brugada, if they have a syncope episode, they're probably going to code on you. So syncope episode should warn you to do a 12 lead. If you see Brugada, Scotty, beam us up. All right. How you identify Brugada? Look at V1, V2. Look at V1. See this right here? It looks like a what? Slant, like a ramp. See the ramp? When you see the ramp in V1, V2, that's Brugada. And if they had syncope episode, I see that, Scotty, beam us up. So what is Brugada syndrome? It is a problem with the sodium channels. Sodium channels are abnormal. They have an abnormal problem or abnormalities with the sodium channels. So that's a big problem because sodium channels, problem with sodium channels and Brugada can throw you right into VFib quite quickly. So when you have a young person dying, most likely this is what it is.
So you treat them like
Yeah, and flame them to the hospital. Oh, sorry. All right. Yeah. Ventricular pacer. Ventricular pacer is a mimic, right?
Yes.
Is it still a mimic?
No,
Why?
because it's
Very good. So this falls on the scarbosa. So is it safe to say that patients who have a ventricular pacer could still have an MI? Can tissue still die? Yes. So good thing for scarbosa criteria.
Why is it that doctors don't like us using scarbosa?
I don't know if they don't like it. I never heard of that.
Yeah.
What about the department?
Well, I mean, when we were talking about it last class, it's like, just kind of like know about it. Like, sometimes the medical director doesn't want us to use it.
I know my doc don't care. My doc says if you know scarbosa and you find it, you use it.
You would like have to prove it with, you know.
You do. You can prove it. How I prove it? If I called it, I proved it. Because I know how to what? Read it. That's it. So right here is the ventricular pacer. So do you see the pacer spikes? Oh, yeah. Now, if I didn't see that, oops, sorry. If I didn't see that ventricular spike, let's say I missed it. What would I call this? 1, 2, 3, 4, close, but not 5, and the slur T.
where do you, no, what? I would go with,
Go. What were you saying? What were you saying?
well, I know it's hypertrophy, I just can't figure out if it's left or right.
Left. Left.